This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1042, recorded on September 6th, 2023. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What's new in infectious diseases, Daniel?
Well, stay tuned and we're going to go through it. So let's start with the quotation. A sad week. I don't know how many of our listeners are aware that Jimmy Buffett has left us, has died in the last week. So I have a quotation from Jimmy Buffett. I am a huge fan of Jimmy Buffett. I have always looked at life as a voyage, mostly wonderful, sometimes frightening. In my family and friends, I have discovered treasure more valuable than gold. So just thought that was really a nice quotation. And, that goes out to not only, family, friends, but all our TWiV friends who have joined us in the last few years. So thank you for being here. Well, let's start off with Mpox, a situation that Vincent and I were discussing last week. There was a news piece, Mpox, China's health authorities fight surge in cases of unknown origin, published in the BMJ. So what is happening with Mpox, right? So we talked a bit about all these dire predictions about what might happen in the US. And a lot of times when a public health response is effective, we don't notice. You don't get any credit. You only get attention when you fail. Well, confirmed cases of viral infection, which primarily spreads through contact with infectious lesions, increased for Mpox nearly fivefold to 491 on the Chinese mainland in July, according to the China's Center for Disease Control and Prevention. So even though we call it the China CDC, they've got a P in there. That was up from 106 cases in June. No deaths were recorded so far. 4 in 5 of the cases had no known origin, according to a post on the China CDC's website. A little quotation here. The reported cases represent only a fraction of the actual numbers, a phenomenon common in almost all other countries. This is from the deputy director of the Stanley Ho Center for Emerging Infectious Disease at the Chinese University of Hong Kong. Couple concerns. None of the 3 vaccines in widespread use elsewhere for Mpox prevention have been approved for use in China. So that's a bit of a challenge. And also, there may not be a recognition of the at-risk populations. So,
Daniel, I'm going to China in November. Do I have to do anything?
No, you don't. I don't think this is going to be a problem for you, Vincent. So just
okay.
All right. RSV, have people seen the advertisements? The vaccines are now available. Actually, I was talking to one of my neighbors earlier today. His parents have actually gotten their vaccines at a local pharmacy, actually. He was touting how nice an experience it was for them. But as we've discussed, the 2 adult over age 60 vaccines are now approved, licensed, shared decision-making for higher risk individuals. But shall we discuss timing? When are we encouraging the high-risk individuals to do this? Well, the nice thing about these RSV vaccines is their efficacy is for a 90% reduction in medically attended lower respiratory tract infection with RSV. And we're already seeing durability out to 2 years. So this isn't something you need to wait. The recommendation is as soon as you can get that appointment, run in and get it, maybe right after the Jewish holidays when my parents head back to this part of Long Island. They will get their appointment scheduled. And all right, I want to just put this right up front because, so I'll call this a public service message. We all need to be on board with this. I want to mention the article, Analysis of Seasonal Variation of Antibiotic Prescribing for Respiratory Tract Diagnoses in Primary Care Practices, published in Antimicrobial Stewardship and Healthcare Epidemiology. Unfortunately, this is an article that serves as a reminder that as we head into winter, when the temperature drops, the number of inappropriate antibiotic scripts goes up. Let's try to not participate in that. All right. And COVID, what is going on with COVID? Just a reminder that people can have more than one thing at the same time, and that can be a bad thing. With the article, Prevalence and Associated Outcomes of Co-Infection Between SARS-CoV-2 and Influenza, a systemic review and meta-analysis published in IJID. Now, with home testing, right, we're often stuck with a yes or no on COVID, but we're not getting this information about co-infection, right? So a lot of people may think, oh, my test is positive, I've had COVID. They're trying to decide whether or not to get treatment. Well, you may get a little bit push left or right, depending on whether or not you have something else going on. For instance, here, what if you also have influenza? So here they looked at folks who had influenza and COVID at the same time, comparing those patients with COVID-19 only. A co-infection had an increased risk of ICU admission, 2.2. Increased risk, the odds ratio for mechanical ventilation, 2.73. And the odds ratio for death, 2.92. So almost 3 times more likely to die if you have both SARS-CoV-2 and influenza. Now, this is an interesting one, and maybe it sort of serves as a stepping off to discuss a little bit about what's going to be on people's mind the next couple weeks here. Actually, what's going to be in the news a lot, I expect, this week. So in the COVID active vaccination immunity section, we have the article Comparison of Bivalent and Monovalent mRNA Vaccine Boosters, published in CID. Just to start with the abstract. So this is a cohort study that was conducted in Hong Kong, where both the bivalent and the monovalent formulations of the BNT162b2s, that's the Pfizer BioNTech boosters, were available. And what they're looking at is they're actually comparing mortality, hospitalization, and here they report no significant differences in the mortality or hospitalization between those who received the bivalent or the monovalent as second boosters. Basically, bivalent and monovalent mRNA boosters appeared equally protective against clinical outcomes when one was looking at disease, not just the positive PCR test. So they have a table we can actually look through and see about, 1,622 folks decided to do the bivalent, 1,622 divided to do the monovalent as the fourth dose. They look at all-cause mortality or hospitalization, respiratory-related hospitalization, basically comparing these across. This is encouraging data, and that moves us right into boosters are coming later this month. Actually, COVID-19 booster shots are expected as early as next week. We're recording this Wednesday, but this will drop Saturday, and that will be true. So first, the FDA is expected to authorize or approve the shots, which they've signaled they're about to do. They kind of need to do this soon because the CDC, the CDC's independent panel of advisors is going to meet on September 12th, next Tuesday, and then the CDC director will sign off. We'll get recommendations on who should be getting those shots. And here, I'm going to talk a little bit. Timing does matter, right? We've talked about the fact that we're expecting this to give some kind of a boost for, let's say, 4 months. And that boost, there will be contraction of those neutralizing antibodies that we keep mentioning. So if you rush out and get it immediately, let's say the end of next week, the clock's already ticking on that contraction. So a lot of us are recommending end of October, early November as a great time to be getting both your flu and your COVID shots. And as we've mentioned, it probably doesn't matter which arm. You can get them both at the same time. I usually pop both into a person's same arm, and then we move forward. All right. Early viral upper respiratory, just a refresher, right? It's people are testing positive. A lot of people are testing positive. Keep seeing those numbers rise. Number one, still Paxlovid. Number two, remdesivir. Number three, molnupiravir. Convalescent plasma only for a specific subset, immunocompromised with no other options. And we are avoiding doing harmful things. Early inflammatory phase, we unfortunately are still seeing folks that, and this tends to be the profile, that first week, they did not receive treatment. They're starting to have problems requiring hospitalization during that second week. They become hypoxic. Saturations drop to less than 94%. That's when steroids, we jump in with dexamethasone, 6 milligrams a day times 6 days. And I will leave a note into the systemic review and a meta-analysis in OFID that is based upon anticoagulation recommendations from American Society of Hematology. I'll leave in a link for those. Pulmonary support, a lot of subtleties there, but starting with nasal cannula and then escalating. Remdesivir, this is now 5 days. If we're after 7, we've ended up here. It's sort of that day 8, 9, or 10 is a 5-day versus a 3-day first week, and immune modulation in certain circumstances. But here's a big challenge, right? People, it's early, they get COVID. A lot of folks are not thinking they're going to die. They're not thinking they're going to end up in the hospital, but they're worried about long COVID. And is there any way right up front that maybe we can predict who's at highest risk? So we have the article, Acute Blood Biomarker Profiles Predict Cognitive Deficits 6 and 12 months after COVID-19 hospitalization, published in Nature Medicine. So these are the results of a prospective cohort study of 1,837 adults hospitalized with COVID-19. The investigators used data from a large prospective longitudinal cohort study, the post-hospitalization COVID-19 study. That's the PHOSP-COVID study, if people are following the acronyms. And this was designed to discover patterns of association between biomarkers measured on admission to hospital for COVID-19 and post-acute cognitive deficits, which they're going to be measuring at 6 and 12 months. And they're actually using a formal Montreal Cognitive Assessment Score to assess cognitive function. So there's actually I'm going to leave a link into a copy of this test. Maybe some people are familiar, maybe they had this done, but this is where you connect letters with a line like A to B to C. You draw a cube, you draw a clock, you name some animals, you remember stuff, you pay attention. It takes about 15 minutes. It's not the hardest test to do, but there's a lot here. They have a lot of nice figures. There's a huge amount of data. But the findings the authors highlight is there is a correlation between certain blood tests on hospital admission with cognitive issues at 6 and 12 months. The most predictive was having an elevated fibrinogen level and a low CRP. Even more predictive was we put these together and create a fibrinogen CRP ratio. Also elevated D-dimer was associated with cognitive issues. We can also create a D-dimer CRP ratio. And these two dimensions were robust across secondary analysis, right? So they do a secondary analysis in a separate large-scale electronic health record. And we see, well, really the D-dimer is really specific to this COVID-19 and the 6 and 12-month cognitive issue. So really worth looking at. What do we do? I guess that's the big thing. Is there any way we can target these individuals early, maybe for a closer follow-up, maybe as we get more evidence-based therapeutics?
What do you think about the CRP D-dimer business, Dan? What is the mechanism, if that's really telling us? It could be just an association, right?
So yeah, it's interesting. There's a lot in this paper where they actually sort of speculate about what's going on. And so there is this idea that, so fibrinogen and the D-dimers, which are going to be the split products of the coagulation, but also the inflammatory cascade, may be telling us something about the degree and the nature of the inflammation that is being triggered during that second week requiring hospitalization. There may even be something here about permeability of the blood-brain barrier, allowing certain pathology to begin early in disease. So lots of speculation, lots of really interesting ideas. But yeah, D-dimers are not just for clotting. They're part of the inflammatory cascade. Same with fibrinogen. So, and I know on some of the other shows have been a lot of coverage of complement. So I'd love to see some studies on that potentially playing a role. All right. And here is a couple more here to finish us off in the long COVID section. The article, Temporal Changes in Fecal Microbiota of Patients Infected with COVID-19, a longitudinal cohort published in BMC Infectious Diseases. So these results of a monocentric, I mean, that sounds fancy, but it just means they did it in one center, monocentric longitudinal observational study to describe the gut microbiota profile in COVID-19 patients, and compared this to a pre-existing cohort of ventilated non-COVID-19 patients. The investigators included patients admitted for COVID-19 on the medicine ward. So these are 43 folks not on a ventilator, or folks in the ICU, with 14 of those on ventilators, with a positive SARS-CoV-2 RT-PCR assay in a respiratory tract sample. 16S metagenomics was performed on rectal swabs from these 57 COVID-19 patients, 35 with one, 22 with multiple stool collections. 19 non-COVID-19 ICU control patients were also enrolled, among which 14 developed ventilator-associated pneumonia. So we have this pneumonia group. 5 remained without infection, so a different control group. And they're doing these SARS-CoV-2. They say viral loads, but we all know they mean RNA copy number in fecal samples measured by qPCR. And they noted that the microbiota composition became distinct between the COVID-19 and the non-COVID-19 groups. And the fecal microbiota COVID-19 patients was characterized by increased Bacteroides, and the pneumonia group by Prevotella. So the COVID-19 presented significant effects on the microbiota composition in this study. Moreover, as they describe, patients in the ICU harbored increased Campylobacter and decreased butyrate-producing bacteria, such as less Lactobacillus, less Rosburiae, less Fecalibacterium. All right.
Daniel, what do you think? Do you think these microbiome changes predate COVID or are a consequence of COVID?
No, so I think they're actually triggered because as they're following these, and 22 of these folks have multiple, so you're able to see this this composition becoming distinct over time.
Okay.
Yeah, and it is interesting. I think we've talked a little bit about this, and I'm starting to get more and more patients with feedback on using the Bifidobacterium probiotics, right? Who are suffering from cognitive issues with long COVID, and hard to sort out how much is placebo effect versus therapeutics. But seeing a lot of people, I'm thinking I'm going to help their gut microbiome, and they're coming back with improved cognitive function. So call me curious, but certainly need a lot more work to better understand this. And the last one, and I think this is just a reminder for everyone out there about the fact that the journey does not end when the person is clapped out of the door. And we have the article, Long-Term Survival After Intensive Care for COVID-19, a nationwide cohort study of more than 8,000 patients published in Annals of Intensive Care. So among the 7,390 patients with complete 360-day mortality data, remember, these are the people that survived that hospital admission, 24% of them died within the next 30 days, 28.8% within 90 days, and it was up to almost 30% over that first year. So the 360-day mortality rate for folks that survived the ICU care for COVID-19, 27.1% for the female patients, 31.0% for the male patients. So pretty Yeah.
Very striking, isn't it?
Well, I think, people have probably heard how upset I would get at the clapping people out. I'm like, this is for so many people, just the beginning of this journey. A lot of these people, well, here as we see, about a third of them will not make it through this next year. This is, you can't just clap them out. Now is the time when you've got to start saying, how can I help these people transition? How can I make sure they're on the right medicines? How can I do everything I can to make sure that all the resources we put into getting them through this ICU experience doesn't just result in them dying in the next 360 days.
Daniel, what's the main cause of death? Cardiovascular things?
It is, yeah. Yeah. I mean, this study, I don't have sort of the specific of these 8,000 patients, but for a lot of them, that's what it is.
Okay.
All right. And as I've been closing for a long time, no one is safe until everyone is safe. We all wish we were done with the pandemic, and a lot of us who wish we were done are being rudely reminded that things are still going on, whether it be COVID, whether it be RSV, whether it be other issues. And we are continuing to do our Floating Doctors fundraiser for August and now September and October. They desperately need your help. They're really struggling financially. And the money you send us, we're hoping to get up to a doubling of your money to a maximum donation of $20,000 to help Floating Doctors continue to do the great work that they do down in Panama.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Barb writes, would you provide the studies you're referring to for 6-day course of dexamethasone for hypoxic inpatient? Our guidelines still specify 10 days. Thank you. Barb is a hospitalist.
Yeah, Barb. So thanks for bringing that up. I brought this up several times, time to update the order set. And I think I was saying earlier last week when I was talking with one of my hospitalist colleagues, Dr. Parnell, who used to borrow my kayak, and now he's got children, is much too busy to kayak. But, when will we update those order sets? And I think at this point, the inertia is there, and the 10 days may just stay. We may have to manually change our duration. But I discussed the article back earlier this year, 2023, which was the article, Optimal Duration of Systemic Corticosteroids in Coronavirus Disease 2019 Treatment, a Systematic Review and Meta-Analysis published in Open Forum Infectious Disease. So as people may remember, these were the results of over 13,000 hospitalized COVID patients, 7 RCTs, 20 observational studies, no benefit beyond the 6 days of treatment. Now you just start getting into all the side effects without the benefit. And I'll leave a link in our show notes, or maybe Vince and someone will leave a link in for us.
Okay, Jay writes, so currently undergoing rabies post-exposure prophylaxis in my family, which led me to do some searching online about how long we'll have protection. From what I found, it sounds like rabies PrEP, pre-exposure, affords very long-lasting protection, while PEP may provide 6 to 24 months. As PrEP is 2 shots, maybe a booster after 3 months, and PEP is 4 shots plus immune globulin. I would love it if you would explain the immunology behind the lower durability of the PEP regimen. The only thing I can think of is that the IG interferes with the full response. P.S. Lest I leave the wrong impression, we will move forward following CDC recommendations. I'm just curious about the immunology underlying the interventions.
Yeah, let's get everyone up to speed on this, because this is really an interesting topic. So you go ahead, like me, and you get yourself your rabies vaccines. And so this is great. You got your rabies vaccines. Like me, you're out there petting all those dogs who may or may not be rabid. And lo and behold, so far this hasn't happened, you get bitten. You have one of those high-risk exposures, break of the skin, dog runs off, you don't know, maybe that dog was rabid. Let's say you're in India where, we see 100,000 rabies cases a year. I've heard these estimates, which I can't believe the number's that high, but that's a number that's been suggested. So what do I do? Oh, I've been vaccinated. It all should be okay, but it's not. And here's the interesting binary. If you've been vaccinated, you don't need the immune globulin. You just get a post-exposure vaccine series. If you have not been vaccinated, then you're going to get that immunoglobulin right up front, and you're going to get shots afterwards. What's the immunology here? So the immunology is that when you get bit, and this is great. I love rabies just from a virology, not from the human side of it. But when you get bitten, that virus initially is not connected to a nerve. It's not migrating through a nerve. It's in the surrounding tissue. And there is a window period when that virus can be neutralized and cleared before it makes contact with the nerve. Once it makes contact with the nerve, it's going to be migrating to the central nervous system at a certain rate per day. So the idea is if a person has not been vaccinated, you want to immediately flood the area with the immunoglobulin. If they've been vaccinated ahead of time, the idea is they're going to be starting to respond, and they're going to be able to provide their own local immunoglobulins in that area.
Charles writes, I'm 71 years old. I've had all COVID vaccinations except for the last bivalent one. I had COVID February 2023, mild symptoms for a week. I had AFib in 2018 that was treated with an ablation. About 5 months after I was ablated, it was discovered I had multiple pulmonary embolisms in both left and right lung areas. Some were old, some were newer. I was put on Xarelto and told I will be on it for life. A recent echocardiogram shows I have moderate mitral, bicuspid, and tricuspid valve regurgitation. I've read that COVID can exacerbate this condition. I've also read that the vaccine can also impact the heart, but not as frequently as COVID does. Since the vaccine appears to provide a diminishing protection against infection while not adding any additional benefit to T cell function, I wonder if I should get the next round of COVID vaccinations.
Yeah, so this is a great discussion. It's good that you have both Vincent and I on board here to give you the perspective. So the first thing is to always ask what are you going to think that booster might provide for you? So you're in your 70s, you have what sounds like a number of cardiac issues, valvular issues, the atrial fibrillation. I don't know if there's other medical issues going on. So yeah, you're an individual with a non-zero risk of progression should you get infected with SARS-CoV-2, should you get COVID-19. The durability of those 3-4 shots for preventing disease looks to be durable. I mean, that is the reassuring message. Now, a booster for maybe 3 to 4 months might get you some temporary, say 4-month decrease in your risk of getting infection. I'm going to call it SPF 2 or something, right? So, you're instead of being there for 15, maybe you have to be there for 30 minutes. Still want to be making smart decisions. But is it really going to impact that 90% that you've got going? I think we have to be honest about what we promised there. I don't think that the vaccine itself relative to getting COVID is going to be a health risk, right? These vaccines are incredibly safe. But yeah, this is not as important as those first 3 shots. The other side that ties directly in here is you're on one of these direct oral anticoagulations, one of the medicines that is metabolized in a way that Paxlovid might have an interference. So another thing that's probably really important, I'm going to say, I know you're asking about vaccines, is talk to your providers about what happens, what's the plan, what's my plan should I get an infection? Is it okay? Do a risk to stop that medicine, that Eliquis for 5-6 days? I think that's going to be the most important thing. Vincent, any?
I think that's the right advice. Paxlovid is a game changer and can prevent some of these other issues that he's worried about. Yep. All right. Don writes, as an old Vincent's age country doc in Kansas, I was intrigued by stumbling onto a PBS special concerning epipharyngeal abrasive therapy. A short internet search indicates that there are some who feel it not only may be a viable adjunctive treatment for long COVID, but multiple other maladies that are not well understood. Since you are one who seems to evaluate literature with more than average astuteness, I would love to hear your opinion. As a function of having been around for a while in medicine, I predict we will see an amazing amount of epipharyngitis in many patients we scope, which would leave us with a conundrum on whom to treat and how aggressively.
Yeah, no, I have to say this is something I'm not familiar with. I'm going to put this in my list of things to investigate, and maybe in the future, if there's some interesting stuff here, I will share.
All right. That's TWiV, Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.